around in the hinterland of the audio-visual background. Can you see my slides? Alice, can you jump up and just give me a thumbs up if you can see my slides?
Yes, we can now. Yeah, good to go.
Cool. So, fabulous. Sorry everyone about that. And apologies I couldn't be there today. I really think that these things are fantastic, and the setup that the organisers have come up with this interactive, collaborative approach is just going to be fabulous. But I should say that today is sponsored by Strepsils Anaesthetics. I unfortunately have got 3 kids at home on school holidays, and I think the system has just gone. Anyway, cracking on. As Alice alluded to, I wear a few hats. So I'm the rehab team lead at Access Sports Medicine. I've been involved with our concussion service since it started in 2016. So I'm very much a clinician. And then a little bit more recently, I've embarked on my PhD. So from the start of last year, I've been working on that. And as of this year, I've got the support of an HRC fellowship. I'm very fortunate. So I'll talk you through, I guess, some of the way that I approach returning someone to sports, and where I see there are a few gaps, and I guess how we're trying to fill those gaps in the future. So now my slides aren't going to want to click through. Oh, here we go. Okay, perfect. So just a little bit of a story to kick us off. This is a really common experience when you're working as a sports physiotherapist. So this is a number of years ago. I worked at an event, it was run by Red Bull. It was a recruitment drive for the New Zealand Sevens. So we had lots of young athletes turn up who we hadn't met any of them before, and you get a bit of a medical handover for the athletes, and then you kind of go from there. These were young guys, so they were sort of 17 to 20-year-olds, and there was 2 athletes in the team that came in with a reasonably significant recent injury history. So one of them had a knee problem. And for that knee injury, he came in with objective limb symmetry index, so force plate data. He had had isokinetic dynamometry, he had MRI scans. He had a whole lot of really useful objective things that helped facilitate my decision making as the sort of medical person. Then there was another chap in the team, and all it had on his file was that he'd had a concussion 3 weeks ago. And that was it. I didn't have anything else to help sort of facilitate how I would, judge if that player was appropriate to be on the tournament field. And that really brought home to me the difference that we see often with concussion, is it's very dependent on having a clinician who's maybe interested or has done a little bit more extra reading as opposed to your average sort of physiotherapist. Now, Petria has set the scene and angle actually really nicely for my talk around the fact that we have a pretty significant sports concussion problem in Aotearoa. But, as Katherine touched on, it's not just rugby. We see it heaps in other sports too. And I think it's that, in my family we have a saying, you get sick or you get sore. So if you don't do any sports, you might get sick. If you do sports, sometimes you might get sore. And I think that definitely sports-related concussion applies. I just want to highlight that there are a few populations that are overrepresented in the statistics. So we see a lot more younger people with MTBI. And we also see a much higher prevalence of Māori and Pacifica relative to their prevalence in the population because of their involvement in some of the higher risk sports that we see greater numbers of. Now, according to the 2023 ACC data, we had about 10,000 concussions, sports-related concussions, in the last year. But it's important to understand that that's quite probably an underestimate. So we did a retrospective analysis of nearly 300 patients that had presented to us at Access. So we are a sports concussion specialty service, so people are being referred for help with a concussion, but just over half actually had a concussion diagnosis as far as ACC was concerned from a read code. So I guess the point with this is that there's a lot of these people out there, and I think the numbers are generally as Petria has mentioned, the second lot of ACC National Concussion Guidelines has just been released. There's my dear friend and colleague Stephen Kara. And this does help in that there is some consistency now around the advice across sporting codes. And we do see things coming through with a kind of minimum time frame of stand down period that is recommended that a player is removed from play. Now, how that 21 days is arrived at was through a variety of different things, one of which was a paper that we published a few years ago now, where this was a cohort of very young, very athletic, minimal kind of other complicating factors that can make a risk of recovery. And we found that less than half of them were right within this sort of 2 weeks window. And this is still something I see all the time in clinic, where people come in and they've read on Google or they've been told by someone, oh, you should be right within 7 to 10 days. There's still this perception that concussion is sort of faster. In this cohort of patients who arguably should be the fastest to recover, we found it was actually only at that kind of 4-week mark where we started to get the majority of people improving. And so these kind of things inform these guidelines. Now, when I've got someone in front of me in clinic, we start to, so at Access, our whole approach is around targeted management. So each concussion presents individually for that individual. It may be different from a previous injury they've had, it may be different to an injury that their cousin or their friend or their teammate had. And so we need to make sure that we are assessing that injury and applying the appropriate rehabilitation principles. So we can kind of group symptom categories. And so what I'm going to talk more around today is the somatic-based symptoms. So these are symptoms and signs and problems that are associated with the physical systems, because that's what I deal with in my scope as a physiotherapist. So people who are having physical difficulties after a concussion can experience so just problems with their vision or how they move in space, neck pain, headache, these kind of things, and some issues when it comes to their exercise tolerance. Now, what's driving these are a few particular systems. So we have our physiological systems, which you can think about sort of how we regulate all those processes that should just tick away in the background, we don't thought into. So things like you get up, your blood pressure changes, you go to run, your heart rate elevates so that you can meet the increased demand of your working muscles, all of those kind of things. We also, within the physiological systems, we can think of how we can regulate things like our temperature or knowing when is time to go to sleep or not. And so these are some of the issues that we see in people who've had some of these things post-concussion. Moving more into our kind of sensory systems, the first one to think about is our vestibular system. So this is the little sensory apparatus in our inner ear that tells our brain about where our head is in space. And it's got two main jobs, gaze stability, so it's got a series of reflexes that help us keep our gaze stable, and also knowing where we are in space. The oculomotor systems is how the visual systems are affected after concussion. So those of you who've had one in the room or known someone will understand that it's really common to have visual problems after a concussion. And often people will say, you know, I've been to the optometrist and my optometry exam was fine, but I still feel like I'm seeing blurry. And it's because the way a concussion affects our sort of visual ability is actually how we use our eyes to present the seeing part of the eye with the target. So you can sort of think about it like other eyes coordinated together. And then we also need to think about the neck, because the forces involved to create all the pathophysiological changes that have been described to you by much cleverer people like me, they have to get to the brain via the neck. So we see a very high percentage of concussion patients with neck issues as well. Often it's kind of a whiplash type mechanism. And some people don't understand that the neck actually operates as a sensory. So we have afferent, or we have information that's going to the brain from the neck that helps tell the brain about where the head is in space. Now, if we just have a look at Cam Roygan here, I haven't chosen him because he's got any kind of concussion history. He's unfortunately rehabilitating a knee injury at the moment, but he is from just down the road from me. He's Oni Whero's rugby club's first All Black. So if we think of Cam in a performance situation here, what Cam has to do is a whole lot of very complex things at once. Okay? And this is important to consider when we're thinking about returning someone to play after a injury. Okay? So if we think of that autonomic process where his engine is providing the fuel to his working muscles, so he needs to regulate his heart rate and his blood pressure, all of these kind of things as he's going about his tasks. He also obviously needs to know where he is in space relative to what's going on around him. So a lot of that kind of preparatory balance, postural responses, reactive abilities, driven by our steering or our vestibular system. And then from a visual point of view, he really needs to be able to take a lot of visual input and process it accurately to know what's going on around him from a visual perspective. So this chap behind him looks like he wants to eat lunch. Okay, so we need his peripheries open. We need him to be able to change from looking at close focus to far, depth perception, all of these things. And this is all happening in a split-second moment, and he shouldn't be having to put too much effort into it. So currently, when we look at the process of someone being returned to play, and I'm talking about your average community level athlete now, not necessarily someone that's under the care of a specialised sports concussion service or someone who has access to comprehensive care in a sort of professional team situation. I'm talking about someone who maybe plays for their local second 15 and they've had a donk on the head, and now what happens to sort of decide about whether they're recovered or not. So there's a few different challenges at the moment. So one of them is that a lot of our current assessment is based on symptoms. So that's your GP might ask you to fill in a form that you score how you're feeling on various symptoms. And this is problematic because athletes underreport symptoms. Younger athletes underreport even more, okay? And we also see this in other cultural groups. So Māori and Pacifica athletes in the New Zealand context are less likely to report symptoms. We also know that there's not a great correlation between when someone feels better and necessarily where they are better. So Mangor touched on that with some of their studies, where people will be reporting no symptoms, but we can still see changes happening in the brain. So symptoms alone are not our best marker of if someone's actually recovered, okay? All of these studies have found that in groups of people who are reporting no symptoms, they've still got evidence of problems with their balance or their landing mechanics or how they regulate their heart rate and some of those things that I mentioned before. The other big issue in New Zealand currently is that it often falls to GPs. So it often is that chap has had his injury at the first 15 or whatever, and then he shows up to his GP a few weeks later and he's saying, yeah, I'm ready to go, let me back on the field, you just need to sign this form. Now, GPs themselves have stated that they're not particularly confident with how they go about this process. And also we know that there's a lot of challenges on the GP workforce at the moment. So they don't have the time to conduct these assessments in the way that they'd like to, and they don't feel like they have the skills, the tools to do that. It's also quite clear that a lot of GPs don't use an objective test. So like I mentioned, we're relying on that kind of simple report. We know that physiotherapists are really, really keen to be involved, but at the moment it's challenging outside of an interdisciplinary concussion team for people to access funded physiotherapy. And the other issue within the physio workforce is that they can vary in experience. So your very classic sideline team-based physio is a junior physio who is often giving up their time for very little money to work with a team on a Saturday. So there's some complications there around their ability to sort of go through this process with a level of clinical reasoning or experience that you get as we get older and wiser. The other thing to note is that within the context of concussion, this idea of exertional testing has been shown to be really useful. So there's been some studies showing that if you take someone who is reporting clinical recovery, they're feeling better, and at rest they do fine, and then you exertionally test them, they will report more symptoms after the exertion. They can also report symptoms specific to some of the sensory motor systems. And there's two studies showing a significant amount of cognitive deficits. So again, they had a normal cognitive assessment at rest, but after exertion, approximately 30% of these athletes had cognitive deficits. So it sort of looks like exertion is a useful way to kind of sharpen our assessment tools, but currently we don't do it. So I guess what's the big picture? Why does this matter that we have these challenges? So at the moment, athletes returning to play are twice as likely to have another injury. Now that injury could be another concussion, or it could be a musculoskeletal injury like an ACL rupture. Okay? And this is a reasonably conservative number. So the studies range, and in younger, there's some studies showing in pediatrics it's up to 4 times of a higher risk. Okay? So what we know is currently there is a large number of players that are probably returning to the field a little bit too soon, and they have ongoing impairments in some of these systems. Now, we don't quite know what is responsible for this increased risk, but we know that these systems that are involved with balance and timing and decision making and all of these things are affected after a concussion, okay? So it's plausible that this is certainly something we need to be looking at a little bit deeper when we're considering assessment of preparedness to return to play. So when I'm sort of looking at returning someone to the field, I start to have a think about the systems. So what's their kind of exercise tolerance? Are they exhibiting normal physiology? What's their visual systems doing? You know, what's happening with their neck? Do they have rate of force development and timing and the ability to kind of resist some of the potentially risky positions that they can get into that might cause another concussion? You know, are they able to dual task and process and do all these things really, really efficiently? And what's their sensory motor integration? How does that look? And what is it like under duress, under fatigue? Because that's what happens in sport. So we kind of clearly need something that helps with this, because it would be fabulous if we could put everyone through Mangle's imaging, but unfortunately that's just not accessible to a variety of, you know, people experiencing these NTBIs. So ideally we need something that uses objective data, so it uses numbers rather than how you're feeling. And it would be great if it could be used by physiotherapists to sort of aid the GP, so it's a collaborative kind of decision-making process. And it needs to be simple and accessible, because like I say, there's a huge variety in how people experience access to care for this, and I want to try and reduce those barriers as much as possible. So that's what I'm looking at with my PhD. So I was fortunate to get support from the HRC for this, and we are looking at kind of this, identify what are some useful clinical tests that need to be part of the protocol, and at the moment we're looking at kind of validating some of those measures, and then having a look at, is this actually feasible within people with an injury, and then we will then look at what's our sort of expected normative performance. And I just want to say a quick thanks to my absolutely fantastic supervision team. I think all of whom, apart from Duncan, are in the room. And as I say, the HRC for giving me some support, and also Access Sports Medicine's been fantastic as a place to work, as a academician, I suppose is a nice way of putting it. And that's my family. So that's the whole reason why I do all this. And I know there's a lot of, I guess, fear and concern around kids and all of the, and I get asked a lot in clinic, you know, would you let your kids play rugby? The answer is yes. You know, to echo Patria's point, there are a lot of positives from being involved in sport, but certainly if my child had one of these injuries, I would want to be really confident that they were completely recovered before I looked at returning them to play. Thank you.
That was fantastic. Thanks so much, Katherine. And we've got some time for questions or comments for Katherine. Yes.
I just noticed the language sports-related NTBIs rather than concussions. Is there a reason for that? Is there a difference between the two?
Good question. So the question, Katherine, is you've used the terms sports-related mild TBI and concussions, and just wondering if there's a difference or a slight subtlety between the different terms. If you could clarify that for us, please.
That's a great point. And you do see them used kind of synonymously. I think that personally I use the terminology sports-related mild traumatic brain injury more with my patients, because there's a little bit of a perception sometimes that, oh, it's just a concussion. But when you look at the definitions, there isn't a difference between the two. We consider those both to be the same. The only difference is sports-related means that the injury occurred during during a sporting event. So I'm often returning people to play after a non-sports-related concussion. So all of these things apply to someone who's, you know, fallen off their bike or hit their head on a garage door, or all of these kind of things. And to echo the point around what Patria was mentioning before, where often from a research point of view, we look at these things in the sporting context. I certainly see a lot of this as being very relevant for returning to kind of high-risk work activities where you need to use some of these systems. So I used to live in Whakapiti in Gisborne, and obviously we've looked at forestry in that area. So things like that, jobs where people are climbing ladders or walking around on roofs, we need to know that they're okay and that their balance systems are working as we'd like them to be before they get back to doing these things where there's potentially a risk of another injury.
Great, thank you. You took the question right out of my mouth, because I guess I was wondering, would this help with like a return to work assessment? But what about those sort of more computer-based jobs? Is there any kind of relevance there, do you think?
I mean, it's not so much in that context. You're not necessarily concerned about risk of another injury, but you're looking at, is the person completely recovered? So I see a lot of visual was a classic one with computer-based tasks, and the person is sort of being considered to be recovered because it's been X amount of time or their symptoms of this amount. But actually, if you've still got a little bit of an impairment, then a really robust testing process can highlight that. So it might be like, hey, we've done these things, we've spun this up, this is what we need to do with our rehabilitation and carry on sort of targeting this particular impairment. So I'd say in that group, it's probably